Okay, you can start.
Hello, everyone, and good afternoon. This is Professor Paul Sidhu from King's College Hospital in London. I apologize that you're not seeing my face, but in this COVID emergency, my webcam has also decided not to work. But welcome to this EFSUMB webinar on the role of ultrasound in COVID-19 patient management. This is a webinar which we have two renowned speakers on the subject, both experts in ultrasound, and both now very recently have become experts in the use of lung ultrasound in the COVID emergency. I'm going to ask all of you to pay attention and do ask any questions on the portal where you can ask a question. And after each speaker, I will actually put these questions to the speakers to stimulate some form of discussion, because as we all know, this pandemic has produced many surprises for us, and least of all has been the surprises of how lung ultrasound examination may enter the protocol for the assessment of these COVID patients. The first topic this afternoon is lung ultrasound examination protocol for the assessment of COVID-19 patients. As you know, many of these patients are difficult to move off the intensive care unit, and using ultrasound in that setting as a portable examination is very useful. So I'm inviting now Dr. Konrad Stock from Munich, Germany, to tell us how he has set up a protocol to assess these patients.
Yes, Paul, thank you very much for the kind introduction, and thank you very much for the invitation to this nice webinar. Yeah, I think COVID-19 is a thing that we're all very concerned about in these recent days, and I'm going to start my presentation right now. I'm from the Klinikum Rechts Isar at the Technische Universität München, and we were also seeing a lot of patients with COVID-19 problems. So I'd like to give you an overview about clinical lung ultrasound in the era of COVID-19. It was really a new era for us because we've never seen something like that before in the recent years. I'd like to share with you some case reports and just give you some impressions. They are brand new from our ICU in the last days and from our normal wards, and hope it gives you some ideas and some pictures in your mind what you can expect if you have to handle with COVID-19 patients. And in the end, I'd like to conclude, of course. So clinical lung ultrasound, why do we really need it on COVID-19 patients? Are they common? Well, I'd like to show you some moments. I'd like to show you some data. This is at the Klinikum Rechts Isar. We are one of two university hospitals in Munich, in Germany, and you can see we always have around about 30 patients on our specially prepared COVID-19 ICU, and we had around about 40 to 50 patients on our normal ward with COVID-19 patients. Some of them were also switched to the ICU when they were not doing better. So this is our algorithm. We had a really fantastic expert team with people from all specialties, and they did a great job. They meet every day, and here you can see everybody who's going to the ICU with special symptoms. First, as Paul was telling me just before, all the hospitals are closed now. You know that from your hospital, and everybody's asked and tested for any symptoms for COVID-19, and we were paying a lot of attention to the respiratory rate and the oxygen saturation, and of course to the temperature measurement. And in our university setting, low-dose CT of the thorax is the first diagnostic tool in these patients with COVID-19. So this is, I know this is quite a luxury situation, but this is very helpful if you can manage to do it that way. So why ultrasound? Paul was already asking this question and gave some of the answers. I think the bedside impression of the patient's lungs is very important. The use of the ultrasound stethoscope provides you more and more relevant information than the traditional stethoscope. I was trained in pulmonology in the Freeman Hospital in Newcastle upon Tyne in England, and I really love this stethoscope. But in COVID-19, it's not that helpful because you have no such big profit. It's really great to see what's going on with the lung, and you're able to do that. I'll show you later on. After that, you've got imaging techniques and CT, MRI, and ultrasound. But we have got a lot of patients who are too ill to be delivered to computer tomography, especially on the ICUs. And you just touch the patient, and the pressure curve is, so to say, changing. So you really have to be careful, especially for these unstable patients. Ultrasound is method, because you simply come to the bed with your ultrasound machine. And in the end, the follow-up of COVID-19 patients would be of my special interest. So can we see signs of superinfection, or can we see a progressive lung involvement? We're all physicians, and we're all not using ultrasound alone. We're using a lot of data. We use all the lab findings. We use, of course, the respiratory information. We use fluid measurements as pickers, something like that. But I think it's always good to have a picture from the patient's lung, and here you can really see changes. And if you document them, that would be really of major interest. So that is daily life. Daily life is changing now. Everybody in Germany is now wearing these masks here. You know it by yourself. I'm happy not to wear one today, although there are viruses on the computer also. So, quid agis prudenter agast et respice finem. Whatever you do, do it wisely and consider the end. This is what Herodot said, and I think this is especially in COVID-19 very, very important, because as we know from China, as we know from Italy, you really have to take care of yourself and of your own health as well. The House of God rules saying take care of yourself. We need you as a doctor are very, very important, and really have to keep them in mind. So we have to be well prepared before we get. So what do we do? Self-protection is top priority, especially in positive COVID-19 infection. The thing is, we need to have the full personal protective equipment against droplet and airborne transmission. And we are really the ones who are in close contact with the patient. So we have to keep that in mind. And we are really the ones at risk. We are not ordering something because we're panicking, but we are the ones who have to be protected, and we have to keep that in mind. And we have to try to limit the scanning time in these cases. Yeah, keep it short. And well, this is so to say a gear sport, ultrasound in COVID-19 patients. We have to prepare which gear to have when, where. And if we're in the room, we're in. We can't really go out and go for more things, for geo or anything else. We have to be prepared, and then we have to do it. And the exam starts before you enter the room. Be in fact ready for the exam is exactly what I meant. As if you're an emergency doctor, you have to decide what equipment I need for an individual patient before I leave my car or my helicopter. This is really important. And of course, adequate hygiene protocols for the ultrasound device. I'll give you some impressions from Munich. Some use protective plastic covers for the ultrasound device. Some say you don't need to do that, you just disinfect it. Well, I think you have to be top level on the hygiene things that are ruled for your hospital. So speak with the guys who are responsible, where the responsibility for that. We've got some special guys who are absolutely hygiene experts, and they tell us what to do, and we can closely in contact with them. So before we scan, we have to wrap our machine. This is the wrapped Reichstag in Berlin, from, of course, here from Christo, and I think this is, I felt a little bit reminded to Christo doing that. This is my team. This is Nurse Johanna and team with for the ultrasound exams, and you see this is our protection clothing in our hospital. We're using these shields because we've got problems with the glasses. I was taking some of the spray you normally use for if you go diving, but it's these shields are a little bit more comfortable, to be honest, and we are using FFP2 masks. This is one of our handheld scanners, and you can see it's also wrapped up completely, and we just changed this this plastic bag after every patient. This is my friend, Professor De Klevert. He's scanning COVID-19 patients on the other side of the River Isar in Munich. This is how he's wrapping up his machine, so to say. He's using a lot of plastic bags. You can get these bags from interventional radiology, or you can also get it from operation theater, especially if you're using big robotic surgery. You have to have these things, and they're quite suitable for your thing. So, how to scan? There was a long discussion how we scan, and the thing is, it has to be quick and it has to be reproducible. And this is the main thing. And in Germany, everybody is now thinking about scanning the lungs. So it's important to have a standardized protocol. Why did we do that? I think we've got a pandemic disease, and we have to share our knowledge and we have to share our data. And I had the idea that it would be a great thing, like in other diseases, when we are speaking the same language. So I brought along together a panel of around about 30 ultrasound friends from Germany and Switzerland and Austria, and we all were having hundreds of emails and sharing ideas. And we were trying different examination protocols. They are really cute ones and very, very complete ones, but they're taking a lot of time. And the thing is, in COVID-19 patients, you have to be quick and you have to be reproducible. This is, so to say, the Volpi-Celli an image, but it's, there are two more regions, this region 5 and region 6, because we found out that this dorsal, cranial, and dorsal caudal are areas very important, because this is, so to say, the highlight level for COVID-19. And of course, for the orientation, you've got the parasternal line, you've got the axillary line, anterior and posterior. And this is where you can place your transfusion, and this is very easy to perform. Also for assistant doctors and young intensive care medicine specialists who have to get into the method very quickly. So I'm not sure whether you can listen to the audio. And this is just to show you, if you lift up the arm, this is one of the main secrets for having a good position for detecting the levels 5 and 6. And this is really important because you have to have a look on these regions. So another thing, this is from my friend Dr. Tom Fitzgerald from Edinburgh. He said, "Hey Conrad, try that, and it's really good." So if you have to have a look on the left side, which we have to do in education, of course, you have to consider the scanning the patient's left side from the left side of the bed. And then you avoid the stretching across the patient, and the face-to-face proximity is not so close. So you have more distance. Keeping distance from the patient is really also one of the main things if you're performing these ultrasound exams. And if the patient is coughing, be aware that you have to consider, do I really can scan this patient, or the risk for me too high? Ask the patient to lift up the arm. Otherwise, you can just lift up the arm like that. If you've got shoulder problems, normally everybody can do
Conrad, if you could speak over the video because it's not being heard so well.
All right. Okay. What I was telling was that the region is well, if you're scanning with the portable devices, there's a big problem that we sometimes are not able to separate one region from each other by a description that can be inserted with a text marker. And what we do is we just put two blank. We just store two black images between every region, so we can separate it and we can post-analyze it, which is quite helpful if we are writing our report right after the extent. Okay, so what I wanted to show you is so to say this is lung ultrasound in the team style. Well, we are of course having more distance, but I just wanted to have it all on one picture. So this is the lung protocol, and we enter the room together. The system is standing a little bit even more distance, and we're just doing the scan and just calling, so to say, the 4 artifacts that are included in the protocol for every region, and then you're really very, very quick. You can handle to manage to scan the entire lung in 5 to 10 minutes, and this is really a very, very good time, and you're very, very quick if you have this team style exam. What you can also do, this is my colleague Professor Lersch, is you can have a device-based exam protocol, and this is a lung ultrasound protocol with the areas from our examination protocol, which is really very nice. And so you can click through the protocol every you have 3 pictures for every region, and then it's going right away into the other region. And so this is especially for young doctors quite nice because they are successfully led through the regions, and if they see something fragmented pleura, consolidations, error bronchogram, or B-lines, they can just store that with a click on the screen, and this is really very nice. This is our protocol, which can be downloaded on the EFSUMB homepage, and you can see we have these 6 regions from the enlarged, so to say, Vorticelli scheme, and we just have these 4 points I'm going to talk right now. And on the backside of this protocol, there's, so to say, a lot of knowledge that you need for this protocol. In fact, all the knowledge you need for it. And again, thanks to Tom Fitzgerald for proofreading. So, how to analyze the lungs? What we are looking, what we're having a look on with these protocols: fragmented pleura, irregular, interrupted, thickened pleural line, partial subpleural. We're asking for consolidation. These are echo-poor subpleural areas with liver or tissue-like tissue structure. And we're looking for an air bronchogram. This is airflow bronchi, with consolidated area. This can in fact be quite nicely seen. You see some bubbles in the consolidation, and this helps you to establish the diagnosis. And we've got the point V lines. You can see that V lines, because it's not only the V lines that we depict in this protocol. Where the classical V lines, they're just the sound of lung water, as you know, and they're described 3 or more bright lines within an intercostal space. But we're also putting the comet-tail artifacts, which are very similar sometimes to the V lines, into this V line category. Why? Because even starters in intensive care medicine would mix it up. And so we said it's more clear if we put all of them in the category V lines, and we just can annotate it for the study so much more easily. And of course, we're looking for pleural effusion. Pleural effusion is a rare thing with COVID-19, but if they're having a bad future, so to say, on the ICU, we unfortunately found pleural effusion to be a thing which is, so to say, a sign which has to be remarkably, which might be remarkably associated with a bad outcome. So what about the published literature? There are some small case report, case series, and there are not a lot of patients included. Of course, it's a disease which is now nearly 4 months old, so you can't expect that there is big data. So that what you can see here, this is the study of 10 with a very small number of patients. You can see lung ultrasound and lung CT is quite nice corresponding in the pleural line thickness in the ground glass shadow, and the fusion is nicely depicted with the blue lines. And so it's there's in fact a big correlation between what you can see in CT and what you can see in ultrasound. Just from Italy, Buonsenso, he was showing his method. He's wrapping up his a Wi-Fi transducer and he's using. I think it's yeah, it's a pad from a big American phone, and it is connected with each other, and then you can of course scan. And this is what he was scanning. You can see changes of the current line. If you have a look at the study of Han, it's only a small number, of course, 20. Then you can see his conclusion was the posterior and inferior areas of the lung are the main important ones, and he was seeing a lot of V lines, subpleural pulmonary consolidations, and pure poor blood flow. This is a point which I find very problematic, because without using contrast enhanced ultrasound, this would be nearly impossible to see. And he's writing that lung ultrasound can provide reference for the clinical diagnosis. I think so, yeah, and I think it's really helpful also for the follow-up. And this is the region of Huang, and these are 6 regions which are quite similar to the ones we are using in our protocol. And here you can see he was doing a correlation between the CT pictures and the ultrasound pictures, and they are fitting quite well. Here you can see this fragmented pleura again. And there's another very quiet group from Italy, Soldati, and he was just writing what you see editorial for the Journal of Ultrasound Medicine. You can get this article from this story number, and it's very nice because he's giving you a lot of ideas, and he was also showing the pleural changing, the pleural changes we already was speaking about. So some case reports in the end. I'd like to show you a 43-year-old patient with pneumonia. The patient was completely healthy, and so it was quite surprising. This is how we do it in our hospital. That is clinical routine. We're using this this protocol on the ICU, and it's really fast forward. And you can see this is yes and no. You can see, yeah, it's he's got a lot of changes, and this is the ECMO, and you can see this is the lung X-ray. And well, I just want to show you some areas. I don't want to show you all of them, but it's just giving you impression. You can see the fragmented pleura here in the right area 1. I see fragmented pleura starting consolidation right area 4, and you can see on the left lung, you can see this large consolidation with bronchoderm in the left area number 6. So what would you expect in CT? And you can see, of course, it would be quite a large number of lesions, and in fact, you can see this is a corresponding CT scan, and it is as bad as lung ultrasound was. And I think it's important to see the CT scan, to see ultrasound side by side, and to learn from other where and which physical modality the biggest advantages. So another case, this is a 60-year-old patient with pneumonia, and you can see, well, this is great, and you can see consolidations everywhere. So she was really showing consolidations, aerobronchograms, fragmented pleura in all regions I was in. No big difference. So what would you think of the CT scan? Let's have a look. This is the CT scan. Just show and you can see, okay, yeah, this is really wide CV. Last but not least, I'd like to show you a 95-year-old patient with pneumonia. And here you can see the different machines. Here you can see this the protocol scan, which is really very nice. If you can install it in your machine, please do it. And you can see this area 5 right, and you can see that fragmented pleura here as well, area 6. And you can see in area 4 again, 3 lines, some fragmented pleura, and in area 6 left side you can also see some consolidation to bronchogram, and very nice patient, in fact, 95 years old, great compliance by the way for the scanning. And you can see the CT scan, and you can see the consolidation condition that it looks quite nice, and it's very much corresponding to the ultrasound picture. I'd like to finish up with a 32-year-old patient with chest pain and dyspnea, and she was just seen quickly in an ambulatory setting by me. So here you can see this is the pocket ultrasound device, and it was scanning her into the infected colon. And here you can see what it does. Without coronavirus too much too early, you can see also the fragmented pleura, and you can also see this epithelial regions. And next I was seeing her in the hospital, and you can try to see what's going on here. So that higher resolution transducer, and this is infecting peripheral lung embolism, and here you can see the muscle vein thrombosis. So I felt a little bit reminded to this case when I started having a look at COVID patients. So I'm not too sure whether the changes that we see in the fragmented pleura and the interactions, and we have to have more information from pathology to find out about that. And I think this is very interesting also for the prognosis. You want to see more cases? If you're German-speaking, Michael Höpfner and Hans-Peter Wester, they did a very nice site, covidzone.com, and you can have a look on it and can get more knowledge and can see more cases. I'd like to conclude. COVID-19 lung ultrasound. Be careful and please be prepared when you perform it. Yeah? You're in danger. If you're not, if you think about the hygiene, no problem. I'm scanning COVID-19 patients for quite a while now. I'm still IgM, IgG negative for COVID-19. So it is possible if you are really protecting yourself, please do it. Work focused. Best use a standardized lung ultrasound protocol. Don't scan freestyle with no idea in front of dangerous patients. And be prepared, know what you're looking for, and best work with standardized lung protocol. And try to participate in local COVID-19 lung ultrasound studies and trials. In Italy, there's a very nice study by Gino Saldati, which is especially for people who are from that region, very, very interesting. If you are from Germany, Austria, or Switzerland, be part of our COVID-19 ultrasound multi-center study team. We just got the permission by the local ethics committee 3 days ago. So we're going to start with it, and we would be very, very happy if you would participate in this study. Last but not least, I'd like say there are questions, if there are questions concerning the COVID-19 lung multi-center study or the lung protocol, feel free to contact me anytime. And I think especially my colleagues from the clinical EFSUMB, Whitmer Brown from the radiology department, my assignment Julia from the pathology department, Markus Schweiger, of course, and of course Markus Hein from the anesthesiology department, as well as my whole nephrology team was Uwe Hiemann for perform that teamwork, even in these days, is the most important thing to do. Thank you very much for the kind attention.
Thank you, Conrad. And I apologize, there was some issues with the sound during that presentation. But one of the things, the questions I've got, Conrad, is they couldn't download the forms of the protocol. Can you put up that web address again, please, while I ask you the next question?
Yeah,
So
no problem. Yeah,
yeah,
the thing is, it's in the EFSUMB, www.efsum.org, or they can send me an email right away.
okay. The other question I have is, do you put ultrasound gel also inside the covering of the bag transducer?
That's it.
What type of
Yeah.
transducer do you prefer? Those are the two questions I have.
I'm completely in this. I completely understand this question. This was exactly what I was showing in the video without tone.
Yeah.
I was telling that it's important that you, if you're wrapping up the ultrasound machine, that you put gel on the transducer first and then wrap it up. Otherwise, you don't see a thing. This is especially very sad if you perform endorectal scans. And the thing is, if you are, we're working with gel in the ICU, we've got the bottles with the gel inside the room, so they stay there, and that we don't put them in another room. And it's also good for follow-up. And another thing for follow-up, if you have a region, only few region, like with this very old guy, we just take a heading marker, just a text marker, and so to say, we mark the places with the biggest changes of the pleura, or with the biggest consolidations, and then we really can follow up these regions. What kind of transducer? The thing is, normally, because of we want to have B-lines. B-lines can be seen with the curved transducer. So we're using normally the curved transducer, but if we're not sure about fluid changes, we go on to the linear transducer. And if you have a pocket ultrasound device, which has normally got a much less attractive B-mode picture than the new machines, you can use the linear transducer right away, because you will see the B-lines because of that technology very easy. So if I use my handheld, I just take the linear transducer, and this is completely sufficient. All pictures you've seen were done with this linear.
I have another question, Conrad. In each of the 6 areas, you remain in an intercostal space and scan up and down, or you scan each and every intercostal space?
Well, what I do is I go. Some call it in Germany the mower, the mower technique, where you like where you go each intercostal space. What I normally do, I go into the intercostal space and move my transducer. Like I wobble a little bit with my transducer alongside the intercostal space. And the thing is, there is mostly a limited number of windows for the ultrasound exam. So normally it doesn't take a lot of time to do that.
Okay. I think that's the end of the questions, and thank you very much, Conrad. We have to move on to the next speaker. Hang on, I've got another question. Okay, let's see what it says. We are talking a lot about areas, protocols, and ultrasound systems. There is confidence about that, but do we have a full consent of tactical aspects? Should we turn off any cosmetic filters, such as compounding, to clearly visualize the pleural lines? What do you say about that? Are you turning off compounding?
Question to me, Paul?
Yes.
Yeah. The thing is, I turn everything off. I want to have nearly a nude ultrasound picture. I want to have the ultrasound picture of the 90s. All kind of compounding, all kind of spatial resolution thing, all kind of Sonus CT. Put it off. You don't need it, because it destroys the artifacts you need for the diagnosis.
Yeah.
Very important.
And another question is, well, if you're doing lots of lung ultrasound in any ITU patients, you've got all these different images anyway. How can you really diagnose COVID, or are you depending on the clinical picture as well?
That's why we're doing this multi-center study. And in our multi-center study, we just not only doing ultrasound pictures, we also add clinical data and lab findings to correlate. I think the future would be that we would have the ultrasound for the follow-up, that we have the CT for the first localization, and that we providing the COVID-19 diagnosis by ultrasound only is very hard. By the way, also by CT, because we had a very high pretest probability for COVID-19. So the CT was very good in the first place, but now it's getting more and more difficult because we're also having other kinds of viruses, influenza, RSV or something like that, which is quite similar. So the pretest probability is going down. For COVID-19, we would have some clinical signs, we would have some lab findings. I think the D-dimer test would be one of the highlights there. And we have the ultrasound picture. But doing ultrasound saying this is COVID-19 would be impossible. But doing the ultrasound and saying, okay, here's something going on which is really affecting the lung, really might be a virus pneumonia. This is what we could do. And in the end of the study, this is what I hope will be one of the conclusions.
Okay, I'm going to have to draw a conclusion to the talk. There are some other questions, but we'll have to move on here. Thank you very much, Conrad.
Thank you very much, Paul, and thank you all very much for the kind of.
Thank you. So if we can now change and move to our next speaker, I'll ask you, the audience to just bear with us for a second while we change over speakers. And
hello to everybody.
Hello, and I'd like to introduce pulmonologist from Bolzano in Italy, Alessandro Zanforlin, who's going to talk to us again about other aspects of the COVID epidemic that we're fearing at the moment. Thank you, Alessandro.
You're welcome. I excuse if some concept will be repeated. I think that almost everything was already said. Let's look. We start from recent history. We know that the epidemic, the outbreak, started from China. Here, the first CT patterns of peripheral lesions of COVID pneumonia was described, and then the first ultrasound findings as already described. Then the outbreak came in Italy. In the area of Lombardia, in particular in Lodi.
Sorry, Dr. Zanforlin.
Please.
We can see the white screen, not the slide.
Oh. Allora.
Okay, now yes, okay. You can run it full screen, like presentation mode.
This way? No?
No, in presentation mode. We can see the preview on the left now.
Okay, I did it.
Okay.
Okay now?
Sorry.
Okay. As I was telling, the epidemic starts from Lodi, the Lodi area. Lodi is the home of the Accademia di Ecografia Toracica. Is an Italian institution, an Italian group of chest ultrasound performers and experts. And from the first moment, our colleague from Lodi told immediately that ultrasound could be useful in the managing of COVID pneumonia. Then the epidemic spread in northern Italy, and many of respiratory physicians, internal medicine, doctors, emergency departments, and general practitioners share many images and videos in our social network page of Accademia di Ecografia Toracica. So much about ultrasound knowledge of this pathology was already and early known by the Italian community, and that made for us the things more easy. A recent census we made in Italy, in fact, showed that right in Lombardia there was a large diffusion of chest ultrasound. In particular, many of the operators were skilled in diagnosing pneumonia. And where the chest ultrasound was not available, that was because of the unavailability of ultrasound system. So unfortunately, the epidemic started where as best it couldn't be managed by ultrasound experts. But the problem is except for protection that already was expressed by the previous relator, is what we need. We need an ultrasound machine. Not all the units have an ultrasound machine. We need to protect it. We need at least an ultrasound system with a convex probe to diagnose COVID pneumonia, but we have to provide a machine to every ward that has to manage this pathology. So in Bolzano, we did the ultrasoundization of the hospital with the aim to give to each department its own ultrasound, to reduce the moving ultrasound apparat between wards, to reduce the need of ultrasound apparat protection, and so to reduce as much as possible the possibility of contagion. The in-ward ultrasound use needed wheeled ultrasound machine, more feasible in open space wards with one filter zone for the whole ward. So you didn't have to cover and uncover the machine to enter and exit every room of the patients. And the ultrasounds are maybe more feasible in single bedroom wards with the filter zone for every room and with a clean corridor. So the alternative are to buy new ultrasound machine, but to do that you have to know, you have knowledge about ultrasound machine, to know the quality of image they provide, to know the problems about its transport, its protection, the battery duration. You have to know the costs, the availability, and the delivery time. Unfortunately, in full epidemic period, if you try to buy a new ultrasound machine, the delivery time were much longer. The alternative is the redistribution of ultrasound machines. So we have recorded unused and underused ultrasound system. We made a technology assessment to understand what was available and what was needed in the new COVID wards. And then was made a temporary redistribution where necessary. The preset we used for diagnosing COVID pneumonia was mostly a convex probe with abdominal preset with a frequency between 3 and 5 megahertz. Filters were off, compound off. The focus was put on pleural line. The depth set at 5-6 centimeters. The gain was low in order to assess the movement of the pleural line as best as possible, and the persistence also was off. So the aim was to examine as fluently as possible the moving images, in particular the sliding sign, reduce the white saturation, and enhance ring down artifacts. We know that lung is normally not visible by ultrasound, but when the disease comes out, it becomes visible, in particular when the disease reaches the surface of the pleura. The typical appearance of the pneumonia is a hepatization with dynamic air bronchograms, but from the beginning of every pneumonia, there is an initial loss of air that come visible as an interstitial syndrome. The interstitial syndrome is an intermediate loss of air of the lung parenchyma. So we can assess the density of the parenchyma with ultrasound from the normal lung in which we see only the surface. We start to assess the presence of B lines that became coalescent in the white lung. The more the lung lost its air, then come the consolidation with air bronchogram, and then finally the atelectasis. So we make a real densitometry of the lung. Because of that, lung ultrasound is an unspecific exam. So when we see a sonographic interstitial syndrome, we can see a ground glass opacity, we can see a bacterial viral pneumonia, an interstitial lung disease, we can see heart failure, IRDS, surface irregularities, or a dysventilation. So let's see what's typical of COVID-19 pneumonia. We already seen what the Chinese colleagues described. Recently, many articles are comparing ultrasound appearance with the CT patterns of the lungs. Gino Soldati has proposed an international standardization of the use of ultrasound with an acquiring of images that could be elaborated by an artificial intelligence system that could give suggestions about the diagnosis of COVID pneumonia. In intensive care units, the protocol, similar to the Munich protocol, was already known since some years. This is taken from the CRT, the Association of Anesthesists of Italy. And the scoring is the same. So starting from normal lung to B lines, coalition B lines in white lung picture, and then consolidations. So in the early stage of COVID pneumonia, you can see isolated B lines starting from little irregularities of the pleural line. Then as the situation becomes more severe, you have larger areas of white lung with consolidation, little consolidation appearing on the surface of the lung. Then finally, you have larger consolidations, in particular in posterior areas, as already described. When the consolidation go on and make themselves deeper in the parenchyma, it's a bad prognostic sign. These are other consolidation. You see that some of them are hepatization with little air bronchogram. Some of them are more anechogenic without air inside. Some consideration about the exam. In Bolzano, we aimed to make a complete covering of the whole available surface of the chest. To facilitate the posterior scan, hand was put on contralateral shoulder, elbow downwards, to move the shoulder blade laterally in order to have more scanning surface of the lung. In the lateral scan, hand behind the neck, with elbow backwards to explore axillary area. In anterior scan, arms are upward to move upwards the clavicula and to explore anterior axillary area. The exam was performed this way by continuous lung scans through intercostal spaces with longitudinal scan, as you see here. This way you can detect the alterations of the parenchyma that appear different from the normal lung pattern. You also have to learn to recognize the lung fissures. Lung fissures are the normal limits of the lobes. They can originate some single artifact that has not to be considered as pathologic. So let's see what's useful for ultrasound in every setting. In emergency department, the role of ultrasound can be to increase the sensibility of the chest X-ray. So in particular, when chest X-ray is negative, you can assess with lung ultrasound if there are signs of pneumonia. So a severity assessment or a diagnosis can be made, and you can decide for hospitalization of the patient. Only when both chest X-ray and lung ultrasound are negative, and with clinical suspicion consistent for COVID pneumonia, you should perform a CT to eventually exclude the diagnosis and dismiss the patient. We used in Bolzano this schema, a little bit different from the protocol already explained. This protocol is made of 10 zones that were divided in base of the anatomic aspect of the lungs. So in the anterior, we had 3 quadrants that were representing the apical segment of the upper lobe, and the anterior segment of upper lobe, and the medial segment of medium lobe. In lateral, another 4 quadrants that were taking part of upper lobe and medium lobe, and posteriorly 3 quadrants. The upper was the posterior segment of upper lobe. The medium is the apical segment of lower lobe, and the lower quadrants of posterior and lateral were part of the basal segments of lower lobe. This mapping with more areas can give a qualitative and quantitative evaluation, and could be useful for the follow-up. So if you perform this exam every day, you can see the changes of the lung from an exam to the other. These are the scoring we have used. We have used a score based on 5 degrees of gravity or severity, excuse me. So the first score is equal to that already proposed. The score 2 is the white lung. Score 3 is white lung with subpleural consolidation. Score 4 is consolidation larger than 2 centimeters. And score 5 were large consolidation that were visible in more than one area of the chest. So the frequently asked questions are: can lung ultrasound replace chest X-ray? Can lung ultrasound replace CT scan? Can lung ultrasound replace the real-time PCR on swab? When lung ultrasound is positive, do you hospitalize patients without having real-time PCR response? So lung ultrasound cannot perform microbiologic diagnosis. It cannot perform also cytohistologic during non-COVID times. Cannot fully replace CT scan, cannot fully replace chest X-ray, cannot replace anamnesis, visit, lab, and patient's symptoms. But lung ultrasound can integrate with clinical data, so anamnesis, symptoms, lab are absolutely mandatory. Ultrasound can also integrate with chest X-ray. Ultrasound have high sensibility, low panoramic view, impossibility of exploring deep parenchyma. Chest X-ray has panoramic view of the whole chest, but has low sensibility for early lesions and minimal dysventilation. Lung ultrasound and chest X-ray together are consistent for pneumonia, so you can consider hospitalization, waiting for swab's response to decide if the patient has to be hospitalized in COVID ward or in COVID-free ward. If both are negative, if the patient is in good clinical condition, you can consider the discharge of the patient, and it can wait also the response for real-time PCR swab at home. Together with chest X-ray, lung ultrasound can make not mandatory the use of HRCT scan. That only when the clinical question is COVID yes or COVID not. That when you have to avoid complex routes to perform CT. That was the problem we had in Bolzano, and you have to limit the number of operators at risk because exposed to the potentially contagious patient. In uncertain cases, the indication of HRCT remains, or angio CT, as indicated by the clinical conditions, as you suspect a pulmonary embolism. So ultrasound can have a predictive positive value for COVID pneumonia, in particular in condition of active outbreak in younger patients and or patients supposed with healthy lungs, in elderly patients with comorbidities during congestive heart failure, aspiration pneumonia, cicatricial outcomes of pneumonia or pleuritis. It is difficult to determine if also a COVID infection is present. On this basis, on published data of our cases in Bolzano, we are reading a sensitivity of 90% and specificity of 75% for ultrasound in detecting COVID pneumonia in the emergency department. So recently a paper from some Chinese colleagues had showed that the sensitivity and the specificity of ultrasound in COVID pneumonia was quite high. The number are unfortunately a little bit few, so the numbers are maybe not so strong. They tried in particular to assess the severity of the pneumonia using ultrasound that in patient already known to have the COVID pneumonia. What we can say is that ultrasound is useful to diagnose pneumonia, so to say pneumonia yes, pneumonia no, and give indication to hospitalization. The severity assessment is only partially possible because the deep parenchyma is not visible, so we have only a partial vision of the parenchymal involvement. Arterial blood gas and clinical data are more useful maybe to stratify severity and decide the correct intensity of cure for the patient. So if they need oxygen, high flow nasal oxygen, CPAP treatment, or needing for ICU. In the ICU, the COVID pneumonia management consists in monitoring consolidation and dysventilation. So my work in the hospital during the epidemic was to perform a daily mapping of the patient in the ICU. You have to consider lung ultrasound for the re-evaluation when the patient is worsening to understand what's happening. So increase in white lung areas, you can consider the change in treatment from high flow to CPAP in the normal wards. When the increase in consolidation determines to consider recruitment and pronation for patient with intermediate care and intensive care units. The monitoring of the benefit of pronation and CPAP can be monitored by ultrasound. You can monitor the recruiting in intubated patient, that making a daily mapping. So you have a sort of comparing from day to another of the general situation of the patient. You have also support to monitor complication in other procedures, so pneumothorax after the positioning of the central vein or a pressure trauma, and you can manage other clinical problems like cardiovascular problems, abdominal problems. So in the ICU, we use this protocol similar to that of the Munich colleagues with a daily mapping and scoring. We can see that we could manage the consolidation, so decide when proning by performing a recruitment test and monitor the evolution in proning position. So you could see that a consolidation became a white lung, so the increase of the air in the lung was visible. That's an example. On the left, we can see the consolidated lung is anechogenic. On the right, after recruitment, there was the appearing of some air bronchogram. So this patient was finally prone to try to improve his lung situation. The medium-term evolution in ICU, I don't know what you are seeing in your units. Is there there are two evolutions. Older and thinner patients tend to have a diffuse pattern with diffuse pleural irregularities and with wide lung, with patchy distribution that remains quite stable during their stay, and also a dimission time from ICU. Instead, younger obese tends to have posterior consolidation with a preserved anterolateral surface. In conclusion, we have seen how the outbreak spread and how knowledge exploded from northern Italy about use ultrasound in COVID pneumonia. We see what we need for performing this exam and how to perform it. Lung, we know, is difficult to be studied in the deep of its parenchyma, but the loss of air let it explorable by ultrasound. So with our scoring, we can assess the severity of the disease, make a good triage and diagnosis of pneumonia, and then manage all the problems we can meet in the intensive care units and other wards. Thank you very much for your attention.
Andrew, for a nice, neat, concise presentation. I have a number of questions for you, and I'll put this to you. One of the questions is, and I think you may have answered this, how many times a day do you do this ultrasound on the patients, and do you do every patient every day? And how many patients does this involve on your intensive care unit, and whether you do it also outside the intensive care unit?
My work was organized this way. In the morning, I was in the intensive care unit where a maximum of 16 patients was hospitalized. So in the moment of the peak of epidemic, we had 16 patients. Every day, initially every day, we try to map the patient. When the patients were quite stable, we try to do it each other day, so one day yes, one day no, but the critical patients were monitored daily. If the situation required it, the other colleagues also in the afternoon performed another exam to see if there were other problems. In the afternoon, I was involved in the triage in the tent of the emergency department to perform the screening of the emergency department of the new COVID patients. So I performed daily about 10 exams in the morning, and what was needed in the afternoon.
Okay. And when another question is, do you change your gown between patients when you're doing your rounds, or do you keep the same protection on for every patient?
In the intensive care, both the environments were considered as contamined. So my gown was put in at the beginning of the session and put off at the end of the session. In the intensive care unit, we used the additional single-use gown only for patients with other multi-resistant bacteria, for example, where an additional protection was needed not to spread other pathogens between patients. But the gown, the general dress for protection, was considered as a second skin. So I held it for the whole session, both in ICU and in emergency department.
Okay. I wonder if Conrad Stock is still on the line, if he can be unmuted and his video shown. But I'll ask another question of Alessandro here. Can you detect fibrotic changes with lung ultrasound? I think this may also be a question for Conrad. Alessandro, can you detect?
Well, yeah, I think. Can I speak?
Oh,
yes.
Here we go.
Okay. I think that there should be a monitoring in the next month of the most severe patients to look for the evolution of the fibrotic residual of this disease. Maybe the time for performing a control CT is as these scarce, these fibrotic residuals become stable, or they disappear. So I think they will need at least 2 or 3 months, not before.
Conrad, there's another question here you may be able to answer. Using contrast enhanced ultrasound, have you used it on any of these patients? Unmute yourself.
Yeah, to be honest, yes. And the thing is, friends of mine in the hospital nearby, they did it already. This is why I was showing the pictures of the peripheral lung embolism. The thing is, in fact, you can see with contrast enhanced ultrasound. Well, if there's a pneumonia, you can. The big thing about the lung with contrast enhanced ultrasound is that you already have two phases. That you again have two phases of the lung perfusion. In fact, you can see the embolisms as like infarctions in the periphery. You can remark it, and what you can also see, if you've got a pneumonia, you can see the hyperperfused areas, and this is what you really can see as hyperperfusion. I was trying to do that with Doppler ultrasound, even with good probes, and the thing is, it's hard because the pocket ultrasound Doppler devices are very limited. And the patient is, of course, breathing, and it's really hard. You can see the breathing rate of the patient with the Doppler, but you don't get a proper signal. It's very hard to get. Sometimes you get it, but it's very it's hard to standardize. If you put contrast media in it, you can see is there a bubble thing, or is there no bubbles inside the consolidation, so you can really see is it an infarction, maybe what I think what was the in many cases the case, but we have to have some more data from pathology into that as well, and I think we have them in 2-3 months. Yeah.
Okay, I'm going to just wrap it up with one final question here, and it's for either of you. COVID-19 causes microvascular thrombosis. Can the ultrasound detect poorly aerated surfaces of the lung? Alessandro.
Can you repeat the question, please?
Microvascular thrombosis, yeah, can ultrasound detect poorly aerated surface of the lungs? I think I can answer this, and I think you probably can, yes, very small areas. We have seen it on our imaging on the ITU, but you got very 3 to 5 millimeter areas of low reflectivity. And this may be microvascular thrombosis, who knows, until we have the pathology. Yeah.
I think that out of the detection capability of the ultrasound, you cannot diagnose microthrombosis from the surface.
Yeah.
I think is quite impossible. You can see consolidations, but you cannot make a histologic exam with ultrasound.
Yeah.
I think if we have the lung ultrasound machines, we were even possible in that also from the kidney septum or from the liver septum. I think due to the air artifact, really see whether it is a vascularization or not in the micromillimeter in the range. But the thing is, you're completely right. We have to have a histologic correlation between that. I think there might be a chance, and there was preliminary data. There was the editor 2 days ago or something like that of the group. I was not sure if it's from Italy or from Germany who already was thinking about it. And they said, "Damn, yes, I'm quicker." I think we might see it, but we have to study it. And if you have continuous ultrasound, it would be really think about, and also for correlation with the ICU. But let's wait and see.
Yeah. Okay, there are many questions here, and I can't take all of the questions because we already run over time by 12 minutes. I thank both our presenters today for excellent talks. I remind the audience that these will be available online on the EFSUMB website. And I thank the audience who have managed to join us here today, and I hope you've found this an interesting presentation, and I hope it helps you in your daily practice. Thank you, everyone. Thank you, Conrad. Thank you, Alessandro. Bye-bye.
Bye.